So on grayscale, prostate cancer is usually isoechoic to hypoechoic. This is an infiltrating prostate cancer in the outer gland. Rarely is it echogenic. Often you can see a contour bulge, especially in more advanced prostate cancer. But how the cancer looks depends on the size of the lesion, depends on the degree of cellular differentiation, and on the fibrotic reaction that you might see within the prostate to the cancer. This cancer here happens to be very apparent. It's hypoechoic. It's a high-grade tumor, Gleason 9 and 10, and that's why it's so obvious. There's a slight irregularity of the prostate contour. There's a narrowing of the periprostatic fat planes. These are all signs of an echotexture abnormality and a contour abnormality, which is bulging into the periprostatic fat. Now, in addition to the grayscale abnormalities, people have done a lot of work using Doppler of the prostate to try to identify prostate cancer. Doppler tends to show increased flow to the areas of prostate cancer. These have been classified either as focally increased flow or increased flow surrounding the cancer or diffusely increased flow. The bottom line is any kind of increased flow is a marker for possible prostate cancer. And looking for increased Doppler flow will increase your sensitivity for detection of prostate cancer. However, as I will show you later, it's not a very specific marker. Prognostically, if you have a cancer and it has Doppler flow, the presence of increased Doppler flow within a cancer is a poor prognostic sign for that cancer. Here is a patient who actually was a friend of mine who had been biopsied several times previously. They could not find his cancer. There was no grayscale abnormality here, but there was increased Doppler flow in the midline here, posteriorly in the peripheral zone. Now, the urethra sits right up here. Increased flow was right over here. So what we did was, and this is power Doppler showing that increased flow in the midline. This is color Doppler showing increased flow in the midline. What we did was we came from the side and biopsied through this area of increased flow. We were able to show Gleason 7 cancer. So let's just look at some more examples of prostate cancer. Here we have transverse images through the prostate going from the base down to the apex. This actually is a sagittal image of the prostate, but this is base, mid-gland to apex. And there's a hypoechoic area with a big bulge of the prostate gland and with increased Doppler flow all along the left side of this gland. And this is a blow-up of it. Massive amount of hypoechoic material along the whole left side of this prostate. Increased Doppler flow. So this is a diffuse cancer which is spread along the left side of the prostate. This is the sagittal image. This is the seminal vesicle at the base of the prostate. There's the apex. Large hypoechoic lesion extending from base to apex. We said there were different Doppler patterns one could see in prostate cancer. Here is a prostate cancer. There is surrounding flow around this cancer. It's a hypoechoic lesion. It's associated with a slight bulge of the contour, and it's associated with Doppler flow around the cancer. Now, interestingly, here's another hypoechoic lesion, and there's increased flow around this lesion, but this is prostatitis. So notice how these findings are not specific. We talk about evaluation of the prostate. It wouldn't be fair to go through this without also talking about some of the more advanced techniques that are being used to evaluate the prostate. One of these techniques is elastography. Another one of them is contrast imaging, and we'll talk about both of these now. Elastography is basically a map of tissue stiffness. And basically, the changes in the ultrasound RF speckle pattern with external pressure can be used to map out the elasticity of different parts of the prostate. And that's creates a picture which we call the elastogram. Most of the elastography systems that are out there right now use that RF speckle pattern and the change of that speckle pattern with external pressure to make the elastogram. There are some newer systems out there now which will use what we call an ultrasound shear stress to create the elastography picture. We're not going to go into the difference between those now, only to say that the newer systems with the shear stress may actually provide a better way of getting a uniform elastography picture throughout the prostate. Here's an example. This is the grayscale image showing you a hypoechoic nodule in the right apex of the prostate. This turns out to be a Gleason 7 tumor. And this is the elastogram in that area. And you can see the dark blue here corresponds to the hard nodule. And the darker color here corresponds to something that is less elasticity on your elastogram. Yet another example, here is a focal hypoechoic nodule. This is a Gleason's 9 and 10, a very, very high-grade prostate cancer. This is the color Doppler showing you markedly increased flow, not only in the lesion, but adjacent to the lesion, probably related to spread of prostate cancer up into the prostate here. But here's the elastogram, and you can see that this lesion is harder than the adjacent normal prostate. Okay, so elastography is one method that has been used, has been described for looking for prostate cancer. That's still under investigation, and we're still awaiting the final analysis as to whether we can improve our distinction between cancers and normal tissue with elastography. Another technique, which is perhaps further down the road, is the use of ultrasound contrast agents. Now, ultrasound contrast agents are a way of looking at the vascularity, and basically what they do is they enhance the acoustic reflectivity of whatever tissue they're in. And in the prostate, they're in the blood vessels. So they're going to enhance the reflectivity and the visibility of the small vessels. There's a nonlinear frequency response, so that even though you are transmitting at a certain fundamental frequency, F0, and you're receiving at that same frequency, F0, when the transmitted ultrasound hits the contrast agent, it also comes back in harmonics of that original frequency. So the fundamental frequency is F0, the harmonics are 2 times, 3 times, 4 times F0, and you can receive those and distinguish that those have come from contrast material. So there are multiple different ways of visualizing ultrasound contrast agents. I'll show you in a little bit some of the color and power Doppler methods, but we actually prefer to use some of the grayscale methods. The grayscale methods use harmonic imaging, as we just talked about before, so you can distinguish what's coming from the contrast by the frequency of the sound that's returning. And there are different ways of doing that harmonic imaging, but basically, once we have the grayscale image, we actually see the areas of increased vascularity as brighter because the contrast agent tends to cause increased reflectivity. This image was created with something called intermittent imaging with a very low mechanical index, so we image the prostate only perhaps once every 2, 3, or even 5 seconds, so we allow the contrast agent to get well into the vascular bed before we image it. And the reason we do that is because the imaging itself tends to destroy some of the contrast agent as you're doing the imaging. So in order to maximize your ability to see the agent distally within the capillary bed, we turn the ultrasound off for a couple seconds, and then we turn it on intermittently. And we also lower the mechanical index as much as possible so that we can still get a good image, but we try to destroy as few bubbles as possible. Turns out that as you do intermittent imaging, the longer your delay between the scans, the more you're allowing contrast to get into smaller vessels. So you have somewhat of a size-selective type of vascular imaging of the distal circulation. But here is an example of the distinction that one might see between continuous imaging of contrast, where you're only seeing it in the large vessels, and you're actually seeing nothing in the prostate, to intermittent imaging of the same patient, where with a 3 or 4 second interscan delay, you're now seeing an area which is very, very brightly enhancing, and this turns out to be a Gleason 9 lesion in the left base of the prostate. Another example, continuous imaging with contrast agent shows you very little. In real time, you could actually see the agent going through larger vessels, but the intermittent imaging shows you a clear area of enhancement associated with a Gleason 6 lesion in the left base of the prostate. So if we want to see the neovascularity, we actually have to use a shorter interscan delay to actually see the vessels themselves. We use a longer interscan delay if we want to actually see the enhancement pattern in the vascular volume. And we try to use a relatively low MI to reduce the contrast destruction. And here's a nice example. This is the prostate. Here's your area of increased echogenicity. This is enhancement of a Gleason 7 tumor. Now remember we said you could have enhancement on grayscale, and here you see it. This is the baseline image where the cancer is not apparent. Here's the bright contrast enhancement on harmonic grayscale imaging. But if you look at the color and power images, baseline color and power didn't show too much, but post-contrast, there's increased color flow in the prostate and increased power Doppler flow in the prostate, and that's very clearly seen after contrast administration. So color and power are other ways of looking at contrast enhancement. The issue with color and power is there's blooming artifact, so it's very difficult to localize things as well with color as it is with grayscale. At the present, to summarize imaging of prostate cancer, half of prostate cancers are invisible with conventional grayscale imaging, with conventional color and power Doppler. And in fact, if you look at it, conventional ultrasound detection of prostate cancer is probably minimally better than chance. And so that's why most people who do prostate biopsies now do systematic biopsies where they spatially distribute the biopsy course all around the prostate to try not to miss something. The future, however, we hope holds better Doppler techniques for cancer detection, identification of cancer tissue with elastography, and perhaps selective enhancement of the neovessels with contrast-enhanced intermittent imaging, and then improved biopsy techniques based upon these improved imaging techniques, which will limit the number of biopsy sites and find more of the clinically significant high-volume, high-grade tumors. So I'm trying to give you a very rapid fly-through of prostate imaging here with some of the newer techniques that are used for prostate imaging. In summary, prostate imaging is done for a couple of benign reasons: infertility, inflammatory processes. When you're looking at infertility, you're trying to see, is there an obstruction of the ejaculatory ducts? Is there an absent vas deferens or seminal vesicle? When you're looking for inflammatory lesions, you want to make sure there's no abscess sitting in the prostate. And then when you're looking for tumor, you're trying to basically direct your biopsies into the area that's going to maximize the positive biopsy yield. Thank you very much for your attention.